You did get to meet our 2 chapter leaders in Florida, but please look them up, join the groups, Larry and Rhonda. You'll get some good stuff out of it. So right now, I want to introduce our first presenter, Dr. Lowell Anthony. We've known for, I would say, a little over a decade. Probably met him back in 2006 or thereabouts. And, well, he's one of the premier experts on neuroendocrine tumors really in the world. And that's not just hyping him up. He this year won our Above and Beyond Award. And NCAN gives this award out every year to the person that we see really trying their best to help patients. So yes, he's an expert, but we're not judging his expertise when we talk about winning this award. We're talking about somebody who really is going above and beyond to help patients. So without further ado, I'd like to bring Dr. Anthony up here. Please give him a warm round of applause. You know how to work that?
I think so. Thank you very much, Bob. It's actually an honor to be here and discuss a topic that chose me. It chose me about 34 years ago. Do you train to become a neuroendocrine expert? No. I think we try to do that now because we recognize all the things that we can do, so we are training people. We're excited about transferring the torch to the next generation. But we were trained by individuals above us that directed us, and with the opportunities that we've been able to take advantage of, we've been able to make advances. And just yesterday, I gave our medical grand rounds at the University of Kentucky, and it had the opportunity of summarizing 30 years of my work in about 45 minutes. It was really reflective because I really felt at the end of that I had just begun. So you think about starting 30-something years ago, and you see, holy Moses, we've done a lot, but good gosh, there's so much more. And it's not like what you did yesterday, it's what you're going to do tomorrow. And that's really where we are today, is to share with you what we've done, but also there is so much that we're able to do now that it's confusing to people who don't see this. And I'm going to start off at the very beginning. The confusion starts with the pathology. You don't know how many times someone comes to the clinic and they basically have been told that they have neuroendocrine cancer, which is probably true. But when we put the word C, when they have that C word after it, it's a totally different biology. And people have to realize that neuroendocrine neoplasms encompass both the tumors and the carcinomas. But it's the it's the neuroendocrine tumors that have a subgroup that are benign. And so when I have someone come to my office to say, I have cancer, and they have benign neuroendocrine tumor, they've been totally misunderstood. And this happens frequently in those tumors in the stomach and those in the rectal area. These are little bumps, and it's misunderstood. Oh my God, you got a neuroendocrine cancer, but it's a tumor, it's not malignant, what do we do? So it's a world of difference to make this distinction. So in the malignant category, we talk about a malignant neuroendocrine tumor because the biology is different from a neuroendocrine carcinoma. And since the biology is different, the treatment's different. Here, surgery is one of the first things we do, chance to cure potentially. Hormonal therapy, somatostatin analogs for the most part, the mammalian target of rapamycin, everolimus, mTOR inhibitors. These drugs are used in transplant medicine. Over a decade ago, we started finding that they were useful in various tumor types. We use tyrosine kinase inhibitors. oral drugs that block a specific pathway. And again, these TKIs are used across neoplasms, not just neuroendocrine tumors. We use a lot of local regional therapy. Let's just treat the disease where it's most likely giving the biggest problem. And then if we do radiation, we'll either do radiation locally, like in the liver with a radioembolization, or we may do more with open source or systemic, where we inject the radiation with peptide receptor radiotherapy. We call that PRRT. Whereas when we work on this side of the equation, neuroendocrine carcinoma, you don't see surgery here. We don't operate on biology that's moving quickly. We use cytotoxic chemotherapy. We have an opportunity now for some of these patients to use immunotherapy, and we use closed source radiation, the linear beam, which you're more accustomed to thinking about going in and getting radiation. So why is it like this? Well, it all starts with the pathology. Pathologist gets it wrong. From that point on, it's magnified. Everything else from that is wrong. So it's so important for us to understand what this grade is. And the grade for the neuroendocrine, this is going to be gastroenteropancreatic neuroendocrine tumor, would be also applicable to bronchials are very similar, but it's not represented on this particular slide. But here, with the mitotic count, when a pathologist looks at the number of cells that are dividing in a high-power field, then they can get an estimation on what the growth rate is when they count 10 or more high-power fields and get an average. And then when that growth rate is between 2 and 20 per 10 high-power fields, they call it a G2. And if it's greater than 20 per 10 high-power fields, they call it grade 3. And this Ki-67 index, this is a stain. So this is where an antibody is put on the slide, and the answer is computer generated because they're looking at the number of cells that have stained. Well, the only cells that stain here are the ones that are in division. So the Ki-67 index localizes to nuclei and cells that are dividing. So now you come up with a machine, I'm going to call it a machine, a computer generated number, whereas this number is more visual. You can say, how diligent was the pathologist in actually doing that? And then the clinical course here, indolent, intermediate, and intermediate here, and poorly differentiated is the different by rapid. Somatostatin receptor, higher expression. 90+% of the time we'll expect to see it. If we don't see the expression of the somatostatin receptor, we wonder, what is this? What is this? And so that becomes a challenge, more of a challenge. Intermediate expression, and then the grade 3 may be lower. The grade 3 are the rarest of these. We don't see as many of those, so we don't have as much information on those, but we do recognize them, and we know to treat them maybe a little differently. Now, when we get down to traditional PET scanning, this is fluorodeoxyglucose. So you probably have heard, don't eat sugar because you're going to feed the cancer. Sugar feeds the cancer. Let's not eat sugar. The problem is that your brain and your heart are powered off of sugar. If you don't eat sugar, your body's going to create sugar to power your heart and your brain. So if cancer is using sugar to grow, then you can put radioactive sugar in there and see it, right? And that's what scientists did 25, 30 years ago, many years ago. They could see we gave radioactive sugar, we can find cancer. Well, guess what? For neuroendocrine tumors, they don't grow right, so the FDG, if you radiolabel glucose, is not going to show up. If it does show up, we're on this side of the equation, over here. I'll never forget when we first started doing sugar scans, let's just call it what it is, sugar scans in neuroendocrine tumors. I was at Vanderbilt, and they were scanning anybody with neoplasm. Just send it to us. After about 20 or 30 of my neuroendocrine tumors, I got called by Martin Sandler, the chair of radiology, saying, Lowell, don't send us any more of your patients, please. We're not seeing anything. I said, oh my God, something. I was betting the future on this, that this is the biology, this is going to make us understand what this is. We had to wait for the somatostatin receptor expression to come out. And so I was very fortunate that Dr. Sandler told me to quit doing this, And then when we look at mutations, the mutations that occur on this side of the equation are different from the equations that occur, the mutations occur over here. So now we can see some of the molecular differences. Well, when we think of neuroendocrine tumors, almost the first word that comes to mind is the word heterogeneous. It's heterogeneous from many perspectives, but one, these tumors derive from cells that are ubiquitous through the body. So these tumors can arise from the skin. We call that Merkel cell. These tumors can arise from the thyroid gland, from the pituitary, from the pancreas, from the lung, from the GI tract, from the gonads. You name it. These neuroendocrine tumors, these cells are throughout the body. And how they present really kind of determines where they started from. So each one of them has their own unique characteristics. So when we think of these we want to think about the ones that are more common, where these cells are more concentrated. And those are the areas that we see more of. And so that would be maybe the thyroid, the lung, the pancreas, and the GI tract. So those are the tumors that we focus a lot on. And when we look, this above the diaphragm comprises about 25% of all the neuroendocrine tumors will start in the lung. So most of them then will come from below the diaphragm. So here 51% and about 6% from the pancreas. So for a lot of our talk today, a lot of our conversation will relate to where the intestinal tract is involved and becomes the primary site. So we talked about the first word that comes to mind is heterogeneous. The second word is misdiagnosis. What is misdiagnosis? Is it because the doctors are dumb? Is it because the patients are totally misdirected? The Google searches aren't taking them to the right website? Is it Google's fault? Just blame it wherever you're going for your information. So what happens with neuroendocrine tumors is that the symptoms are vague. Symptoms are vague. So how can you all of a sudden attach a malignant, particularly a malignant diagnosis, to something that seems trivial? I'll never forget seeing a 70-year-old man came to see me because he was flushing. People were saying, oh yeah, the male menopause. Yeah, male menopause. I'm not sure even today I believe in the male menopause. Okay, I think if a 70-year-old man flushes, that's not physiologic. We need to look into it. If a female is flushing, there's two different things that go on. There's physiologic flushing with menopause, and there's also pathologic flushing with the neuroendocrine tumor. So someone needs to understand that a menopausal flush is not the same as a carcinoid flush. And that's difficult too. Vague, complex, misdiagnosis. It all comes together of why there's delay in diagnosis. It's not because you failed, it's because it's so common. You're hidden. It's like seeing a deer in the woods. It's camouflaged. So, what has to happen to get diagnosed? Either you get lucky and undergo elective, I'm going to say for the female, if you undergo elective pelvic surgery and the doctor looks up and says, oh my God, I looked up, saw the appendix, and I saw a tumor up there, and I took it out, and there was a neuroendocrine tumor. Holy Moses. Never would have known that would have been a problem unless you had a surgery. Or a gallbladder. Someone goes in, has a cholecystectomy, and lo and behold, they have a little bump on their liver. Cut that out. Oh, you've got a neuroendocrine tumor. Or they find some other, serendipitous is the word I'm looking for. So if you're going to catch it early, it's going to be serendipity. You fell off of a horse. You had a CT scan. CT scan showed a mass in the terminal ileum. Got it early. The problem is that most people, because these symptoms are relatively vague until something else happens, pain, involuntary weight loss, maybe severe fatigue, but if you look at the gut neuroendocrine tumors, flushing and diarrhea, potentially, and that's accompanied by severe weight loss, marked involuntary weight loss, significant weight loss. So I would say that generally the minute pain hits, you get diagnosed. Ooh, pain, ooh, that's not good. By the time pain hits, something's spread somewhere, right? That's the risk. Not always, but that's the risk. That pain triggers a CT scan. You don't have to get insurance approval if you got pain. Man, you get pain, man, you go straight to the CT scanner. Don't stop and ask, go from an insurance company. You have it. And so by the time you have flushing with another symptom that's markedly severe, you get diagnosed properly. This is a really interesting statistic. We're seeing a greater incidence of neuroendocrine tumors, and that translates into a greater prevalence because people are living longer. And so neuroendocrine tumors now rank number 2 among all the GI tumors for prevalence. So it's getting up there above 200,000. So we're it's hovering around 200,000. We're trying to keep it below 200,000 because it's a rare disease. Once it crosses 200,000, then there'll be potentially less resources for it because now it's a common disease. So we're in that potential era of it not being as rare, considered as rare. So why is this? Why did that occur? Over about 30, 40 years, we've seen an increased incidence. Well, we've got better diagnostic skills, more education, more things to do, so people want to diagnose and see it. So there's a number of factors that go into it, but I don't think it's really a national health emergency where we have to really think about it becoming epidemic or pandemic or so. It's interesting to see that the mean number of healthcare providers that a patient may see before a diagnosis has been estimated to around 6. That these symptoms have gone on for a mean time between 4 and 5 years. So that's pretty typical because it's an indolent disease. And then in terms of non-productivity, these symptoms at some point will end up causing people to change their lifestyles and potentially not work any longer. The other part, we've talked about neuroendocrine neoplasms being poorly neuroendocrine tumors or carcinomas. We've talked about neuroendocrine tumors being benign or malignant. Now we can talk about non-functional or functional. When I entered this area, I thought everybody was functional because everybody that came into my office had symptoms. Not everybody's symptoms. But it ends up really only a small percentage, about 10% are actually functional. And that just simply means that they have symptoms that are hormone related, carcinoid syndrome related symptoms, or symptoms that are specific for a neuroendocrine tumor. And I'll never forget a patient that only had symptoms on Sunday morning. It was the most fascinating neuroendocrine tumor patient I ever had. And if I can guarantee you, if you go into any physician's office and tell them that you get lightheaded and dizzy and pass out only on Sundays, you're escorted to the psychiatrist's office, okay? What disease knows Sunday morning? Well, it's interesting because if you talk to the patient, she'll tell you exactly why, if you choose to talk to your patient. So what you do is you take a timeline. What do you do Sunday morning that's different from other mornings? So what happens on Sunday mornings? You delay eating. So what she was doing was a self-imposed fast. So what happens when you fast and you have a neuroendocrine tumor that makes insulin? Your blood sugar falls. They fast because you're going to church. You don't eat. Your whole lifestyle is different. And you put all that together and it really makes a lot of sense. So functional is extremely important because we want to control those symptoms. We want to know where those symptoms are coming from, where they derive from, and attack it head on. When they're non-functional, these are symptoms of pain or involuntary weight loss. You can see that these symptoms could play over to these symptoms. If you're flushing a lot, you could start in having diarrhea. You could start having weight loss and abdominal cramping from that. And when it gets to the point of where there's either bleeding, severe anemia, or jaundice, these things put people in the hospital or put them into a workup at a faster rate. And then non-functional, on this side, there's still the hormones that are being secreted potentially, but they're not secreted either at the level of causing symptoms or they're secreting hormones that are bioinactive, meaning that they're not the right form of the hormone that could cause havoc. So when we think of carcinoid syndrome, the first thing we think about serotonin. It's a lot more than serotonin, but that's the intestinal gut carcinoid is serotonin. We don't see it from the pancreas. We don't see it. We see it from the lung about 20% of the time. But when we think about serotonin, we think about carcinoid arising from the gut with liver metastases. So the incidence is 8 to 10% is what it's been estimated. The flushing, the symptoms, flushing, diarrhea, and in about 10% bronchospasm. And then complications, carcinoid heart disease, fibrosis, pellagra, carcinoid crisis. And then we look at liver metastases as the culprit. This is where the disease hangs out. This is where the serotonin is coming from, being secreted into the peripheral circulation. So if you do those things that increase abdominal pressure, if you push down where there's pressure on the liver, if you roll over, bend over to tie your shoes, these kinds of maneuvers could make someone have a flush by simply manipulating, putting pressure on the liver where these tumors are present and pushing some of those bioactive substances into the systemic circulation. So when we say it's a lot more than serotonin, these tumors secrete histamine, a group of compounds called tachykinins, prostaglandins, and catecholamines. And then when we think about all the symptoms that someone could have, truly diverse. The syndrome is well defined over here, but when we look at the respiratory system, those symptoms could be cough and wheezing, dyspnea, the GI tract listed here, skin, cutaneous flushing, apparent cyanosis, the heart. We'll talk more about this a little later, but this is what we really want to be focused on to spare is someone carcinoid heart disease, and also be aware of pelvic fibrosis. This is a typical flush in an individual, carcinoid flush. It's usually upper body, neck, face. It's dry. It's a dry flush. Usually lasts for a few minutes. There's an atypical flush that we see with bronchial carcinoids. That flush lasts for 30 minutes or an hour or more. That flush will be associated with facial edema, fluid around the eyes, periorbital edema. So it's an atypical flush. And that's mediated more by histamine coming from the lung primary. This one is probably more related to substance P. This is a neurokinin, one of the groups of compounds that listed on the previous slide. If you give somebody just a tiny amount of substance P, I'm talking about just a few picograms or so, you'll turn into a stop sign. You'll be so red. We tried this by trying to radio-label substance P, and when you just give a tracer amount of it, somebody can't tolerate it. But if you radio-label serotonin, nobody flushes. Serotonin doesn't cause a flush. Histamine will, as we talked about, atypical. And we think that the tachykinins, and specifically substance P, is one of the big mediators of the carcinoid flush. Catecholamines can also be released, prostaglandins. The frequency of the flushing, 60 to 90%, is a range in the literature. The typical presentation we talked about, often there's a warmth, occasional lacrimation. That's more the atypical part. itching, palpitations, edema, diarrhea, and triggers. These are the things that in the history is critical. We talked about just physical exertion, change of position, but also certain foods, specifically drinks containing alcohol. We used a specific sherry when we do a provocative test, and this is Jerome Feldman's work from Duke. He had the sherry test. We would take sherry from the pharmacy in the hospital and give it to someone and then measure the different mediators that would be released. So alcohol is definitely, for some, a provocative stimulant. So if you're being treated and you're suppressing that, then people can still drink alcohol. But the rule from our perspective is we don't want our patients flushing. We feel like having that exposure to these mediators is not a good thing. So these diverse, let's see. So we've talked a little bit about these characteristics. This is the histamine, the serotonin substance P, bronchospasm. These are what would be listed for this as well. Would be focused more on what's going on with lung function, certainly cited to it. Carcinoid heart disease. This is the right ventricle, the right atrium, and the tricuspid valve here is thickened. The valve leaflets are retracted, and there's a big hole here where the blood is not being pushed forward, it's going backwards, and that would be caused, we would be seeing fluid back up in the legs. We know that when carcinoid heart disease is present, we know that 5-HA is a problem. If 5-HI is going up, we know that that's not a good thing, that so they don't live as long when they're symptomatic. This is really where my practice is really focused, is try to keep whatever we can do to get these 5-HI levels under control. This is a picture that is used in teaching radiologists. This is pathognomonic of a carcinoid. When our radiologist sees this on a CT scan, it's first diagnosis. So this is sort of the wheel and spoke picture on a CT scan. This is the liver, stomach, I believe, up here, and and this is small bowel, and the small bowel is being retracted. It's being pulled down by scar tissue. When this tissue is actually looked at, there's potentially very little tumor in it. There's a lot of scar tissue. We call it desmoplastic reaction, for a technical name for it. Carcinoid crisis. I suspect everyone in the room sits and wonders, is this going to happen? What is it? How do we provide it? How do we prevent it? What's carcinoid crisis all about? So in the days that we didn't have inhibitors such as the somatostatin analogs, we would do things to people and not have them blocked down. So if you went to do a surgical procedure, endoscopy, if pressure got put on that liver or so, then you would have a release of these vasoactive substances. And what those substances do, they lower blood pressure. You lower blood pressure and you start pumping fluid in there. Sometimes it may or may not work. So the problem here is trying to get the blood pressure up. We use drugs, catecholamines, that actually make the tumor secrete more. So it's a vicious cycle. So the carcinoid crisis would be the sudden release, the uncontrolled release of these mediators. We need to, people whose symptoms are not well controlled are the ones that we feel like are at greatest risk. People who are blocked down, getting monthly somatostatin analogs, having minimal symptoms, I don't consider the risk to be very high in that case. So we've talked about flushing. Diarrhea is just as serious a problem. When people come to us with diarrhea symptoms, we have to look at it from, is it related to the disease? Is it related to the drugs they're on? Or is it related to their surgery? Or do they have a totally different condition, another condition? So when you look at all the different areas of someone could have diarrhea, we need to address it and take down each one of those causations. So this is where in many medical oncology practices, this is not what they do. In a lot of GI practices, you'd think the gastroenterologist is focused on diarrhea. Well, they are. They do a lot of irritable bowel syndrome, but they don't do a lot of carcinoid syndrome. Endocrinologist the same way. At the end of my grand rounds yesterday at University of Kentucky, an endocrinologist comes up and says, I just saw one of the worst cases of diarrhea in my history I've ever seen. And he just started taking down all the ways that I can't help this woman. And I said, we need to, we don't even think she's got carcinoid. But you see what happens in this world when it looks like a duck. And this patient's quacking like a duck. But guess what? We can help them. But it's not going to come in where we say, hey, you're one of these wannabes. I don't know if you've ever heard of that term. But people have symptoms. No one can explain it. They sound like carcinoid. I want to be a carcinoid because that explains everything. Well, guess what? There's other things that can look just like the carcinoid syndrome that's not. And it's best for us not to label you for that if it's not necessary. So do I follow these people in my clinic? Yes, I do. Why? Because nobody else will. They don't have a neoplasm, but I can help them. And I don't have too many of them, fortunately, or my clinic administrator would shoot me. Look at all the options that we can do now. I've only listed 7, and the number 8 here is almost anything. And Dr. Strasberg will go into almost anything, what's coming. Somatostatin analogs, the mTOR inhibitors, Telotrestat, this is inhibitor, this blocks serotonin. We'll talk more about that later. Sunitinib, a TKI, tyrosine kinase inhibitor, CAPE-TIM, capecitabine temozolomide. This is oral chemotherapy, local regional therapy, the PRT, future therapies. So what's unique about this is 4 and 5 are for pancreatic primaries. We don't use that very much. We do for intestinal, but it's off-label. It's not some of the early things we do. So this is some of the complexity of when you go to a physician that doesn't see a whole lot of these. You can see, when do I use this? When do I do this? What order effect? What do I do first? And the rule of thumb is do no harm, Hippocratic Oath. So if you follow the Hippocratic Oath, you want to do what's going to cause the least harm. So that's the order effect, cause the least harm. So you can say it takes a village to take care of these patients. In the last 8 years I've been at the University of Kentucky, I've put together over 30 people that have something to do, a touch, that helps me put these people through the process of evaluation. It all starts up here with the pathologist. Once the pathologist classifies it as a neuroendocrine tumor or neuroendocrine carcinoma, then we get the right scan. Then it either goes to our tumor board or it goes to a molecular tumor board, because now in the world of neuroendocrine carcinoma, we base it a lot on what the genetics and what the precision medicine is going to dictate to us as optimal therapy. When it goes to the tumor board, then the patient could be diverted more to medical oncology, could come down to surgical oncology if there's a role for surgery, interventional radiology for local regional therapy, could go into a clinical trial. And what's really exciting is the nuclear medicine part. This is the latest that we had last year, the PRT in January of 2018, on January the 31st at 11 p.m. that night, just before the stroke of midnight, the FDA approved the drug. Actually, it was 11 a.m. But they literally made it a last-minute approval. It was unbelievable. Well, anyway, we now can really help people and change their quality of life, improve their quality of life, give them added quantity of life with nuclear medicine. So this is a small group that we had together among our 30 for this year's Neuroendocrine Cancer Awareness Day on November the 10th. And so you might recognize, maybe this is Dr. Shahan here. These are our patient intake coordinators. This is one of our famous patients that are local, that's one of our advocates, and we had the opportunity of doing that. So when people come to me and say, this neuroendocrine tumor makes me too tired, I have to turn and tell the story about this gentleman. This man came in with a small bowel NET, florid carcinoid syndrome, uncontrollable. Probably between 60-70% of his liver involved by the tumor. We could see the primary sitting in the small bowel. Take him through our algorithm of tumor reduction and stuff. Within 18 months, this gentleman set a new world record in weightlifting and lifted 3 times his weight, receiving somatostatin analogs and everolimus, mTOR inhibitor, Afinitor. So when you read about Afinitor fatigue, I'm not trivializing fatigue, but what can be done on these drugs is phenomenal, setting a world record for weightlifting. So it's Mr. Mark Steiner, he gives us he's a patient advocate. He's put his name out there. He lives in Cincinnati. He's a phenomenal gentleman, and he and his wife have become, I think, some of our biggest advocates in the Cincinnati area. He's a wonderful gentleman, and I'll stop right there.